Welcome to the Clearly Beneficial podcast, the show where we rip off the Band-Aid and explore the future of healthcare, benefits, and the people driving innovation in the industry. This episode is brought to you by Health Next, the company leading the way in helping employers build enduring cultures of health and well-being, reducing medical cost trends, and increasing organizational performance. To learn more how they can help you, visit healthnext.com.
Due to a technical glitch for this particular episode with Nathan Baar, Nathan's video will be live and me as your host's video will not be because I forgot to put on the self-view camera. So you'll see a static image of myself for this episode. Hey, thanks so much for joining me today. I'm so excited to have you on the Clearly Beneficial podcast.
Yeah, thank you, Vinny. No, I'm super excited to be here. I've appreciated our LinkedIn conversations, and it's great to have one over your podcast.
Well, no, that's excellent, Nate. I feel like you're one of those standouts to me on LinkedIn. Someone who brings to the fore interesting conversation, challenging posts. I mean, I definitely you like to be a little bit provocative, the way I like to be a little bit provocative. So I like that. And I think it's super important to open up the forum of my audience, whom I believe are healthcare people, insurance people, professionals. Anybody interested in healthcare. Those are the people I'm reaching with this podcast, and I think they're going to be interested in what you have to say about Health Bar and you and your background. So let's start there. Your background, you started as a nurse or trained as a nurse, was a practicing nurse and a nurse manager. So start there. I mean, how did that come about? And then when did that light bulb come on to say, I want to be an entrepreneur?
Yeah, no, I actually started out at pre-med. So I was a guy, trying to fit the typical stereotypes. And so I was like, oh, I should be a doctor. And found that my core value set and kind of who I was, led me to a nursing profession, which I'm super happy to have found. But I started practicing in the emergency department. You talk about a initial clinical experience in the ER, and you definitely learn a ton and get exposed to a lot. You grow up really fast, and so got into that environment. Knew I wanted to do more, and so took the administrative route. Got my master's in healthcare administration, and got those coordinator, manager roles. Eventually became a director of emergency services for a University of Michigan hospital. And I would say that role really opened my eyes to the business side of healthcare. The other roles were more personnel management, clinical operations. You're still doing some patient care, but becoming a director in a larger health system and seeing how healthcare is reimbursed, seeing how healthcare is incentivized, strategically planning for certain service lines. And we always talked about growing revenue and growing patient volumes. It's like we're healthcare providers and we're banking on people getting sicker and charging more and having that be our future. And I was like, that seems completely opposite to the profession of healthcare. We should be healing people and reducing dependencies and really empowering individuals. And so as I was having those conversations, there was this really weird dichotomy in my head of this is the business side, but then this is the clinical side. It's like, what are we really going for here as a health system? And that's where some things started firing, and I started asking questions. I think health systems really want people in them that just say yes, or it's like, of course, yeah, let's do that, let's go. But when you start asking questions and really drilling down, you start seeing where some of the motivations are within the system. And so it was really.
What was the biggest surprise? I want to jump in because I mean, you just talking about firing in the brain. You fired off like a lot there, and I love it. What was, first of all, the biggest disconnect between the education and going to school and studying, for your master's, and then landing in a system? I mean, what was the first big sort of disconnect there?
Yeah, I think when we talk about, in my master's, we talked a lot about population health, and we talked about systems of care, and we talked about a lot of the things that I think were maybe altruistic and hopeful and that we should be doing. And then you go into the actual practice of that, of that leadership role. And those weren't the things we were doing. And so there was a lot of things we said we should be doing. Then you look at the actual actions of what we were doing, massive disconnect between those two things. And that was like, okay, if we're talking about all these things that we should be doing, but none of them are actually happening, like what's going on here? It
Right.
was just, it was a very strange experience. Yeah.
Yeah. No, no, that's amazing. You know, I think the reality is so far detached from the theory of healthcare. I mean, and to your point, I've thought about what you said many, many times in my insurance brokerage career about, looking at hospital systems going, how can they survive if they don't keep, so to speak, butts in the seats? The idea is,
Mhm.
and all the things everybody's, threw lip service at over the years was, outpatient services, outpatient surgery, all the outpatient stuff. Yet you
Yep.
still better have a full ICU if you want to ring the register, right?
Yeah, no, you talk, and it's funny to see all the consolidation that's occurred across our industry and the strategy around consolidating health systems, right? Economies of scale, better purchasing power, you can negotiate with payers a lot better. But then when they started gobbling up all of these outpatient facilities, they started charging facility fees for
Yep.
inpatient units
Right.
to these outpatient services. And now you have $1,000 bill here and $1,000 bill there, and
Yep.
you see your revenues increase. And so the premise that consolidation is better, that it'll be cheaper, better access, better quality, all these things, I think has proven out in spades that it does not happen that way.
No, and then I look at the cost of even like I take my wife and I take my dog for a walk, and a large university health system here in Sacramento, California, is building a brand new hospital tower, and I watch the girders go up every morning. And I remember being at a conference about 2 years ago where the interim CEO, threw out a number of what the total cost of this thing was going to be, but he boiled it down to the cost per bed, and it was $30 million a bed. Ultimately when this is up,
Incredible.
and so
Yeah,
again, it comes
incredible.
down to they got to pay for that thing somehow, and they're only going to pay for it by keeping the beds full. So I mean, to your point, it's a lot. So at some point along the way, you're working in a hospital, university hospital system, and you're saying to yourself, there's got to be a better way. Where do we go from there?
Yeah. 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 There was that kind of mental realization. And my whole career, I've been a problem solver. It's why I thrived in the emergency department. You have stuff come through through those doors, and you got to make a snap decision. You got to know what your resources are. You got to get in that problem solving mode. And I thrived in that environment. And then took that skill and you just apply it to a larger systems level thought process. And so as I was encountering these problems or maybe perceived problems in my mind, but not for the health system, I started thinking about what would be the way to solve this if we're dealing with this and that and whatever else. And so I started conceptualizing what Health Bar has become when I was in the health system. And I actually tried to implement some of the changes that we're doing today at Health Bar in the health system, which was not responded to well. And you can imagine you're in a system that wants yes people, and you're pushing against the walls with innovative thinking or different
Yeah.
ways of thinking. And I wasn't making many friends towards the end uh, of my time. And it's so, but yeah, it took a couple years. I mean, it was a couple years of seeing and understanding and living it and breathing it, and getting that pushback to really fully understand, like, okay, it's an uphill battle, but it's definitely something that's possible.
Yeah. And so, I noticed on your LinkedIn profile that there's a couple of entrepreneurial, couple of companies listed on there before Health Bar. Are those things like are in parallel to Health Bar, or those things that have been sort of iterations before Health Bar? I mean, maybe just take a second on that.
Yeah, the other business opportunities have really been offshoots of our primary work at Health Bar, and we can get into what that is. But one of the things is that I think you quickly realize in the world of healthcare entrepreneurship is that the system is very broken and that there are a lot of opportunities to solve problems within that. And so trying to align Health Bar underneath a specific core focus, and then allowing these other business ventures to find their own identities outside of Health Bar in those focuses. So whether it's related to healthcare staffing or staffing in the industry, more efficient ways of doing that, whether it's supply chain related in the healthcare industry, there might be efficiencies from bed placements on post discharge and assisted living and skilled nursing bed placements. So every almost linkage in that ecosystem is ripe for opportunity. You see a ton of healthcare entrepreneurship occurring right now because it's a lucrative industry that's wildly inefficient, and you're seeing people come with solutions to make it that much better.
Yeah, I mean, and I look at that ecosystem, right? And I say, is it the status quo isn't good, right?
Mhm.
But are all these, how do we get these fresh ideas like Health Bar to market? But let me, before I go down that road, why don't
Yeah,
we talk about Health Bar? Now, let's talk about the
yeah,
company. You're the CEO, the founder. Let's talk about the mission and what you are trying to do with Health Bar. What's the mission? Where are you doing it? Who are your ideal clients? Et
yeah.
cetera. So let's tell the story. Let's talk about the company a little bit.
Yeah, the original ideas were coming from my time in emergency medicine, where we would see patients come to us for chronic disease management. I mean, things like work notes and prescription refills, and really using emergency care as a source of primary care, and seeing how inefficient that was, and wondering why we weren't doing anything else about it. So that's really where the industry segments of Health Bar came into play. Also seeing our primary care providers being overburdened with patients where their patient loads were, two, three, 4,000 patients that they had to manage, knowing that was completely unsustainable.
Yeah.
And they were just turning into funnel mechanisms for the healthcare system, quite honestly. And so looking at that and saying, if we were able to tackle this, how would we do that? And that's where Health Bar's idea came from. So what we do is we provide, and we've really gone to businesses, to schools, and different population centers. Said, what if we could provide them a form of primary care that was relationship based, value added from a prevention standpoint, increased access, and really looked to that longitudinal relationship of it. And so what we'll do at Health Bar is we've found and developed a system that can take on-site healthcare, virtual healthcare. You look at nurse navigation, look at all these different elements of really outpatient healthcare and bring them to an employer, a school, those different populations, and provide it in a value-based care approach. So we say we're innovating in primary care delivery with Health Bar. We're also innovating on payer model mechanisms within Health Bar. And then also on that medical philosophy, we say we go to school and we're taught how to be clinicians, but really taught how to do procedures, how to treat illness. We get almost no education on what actual health is. So nutrition and, more of these functional medicine, almost
Right.
behavioral medicine topics. And so you got a lot of the influencers out there and people talking about longevity medicine and health span and all that good stuff, which is great. How do you take those concepts and marry them with a traditional medical approach? And we say take the best of both worlds, right?
Right.
There's a place for an antibiotic, most definitely. But wouldn't it be great if in the beginning you optimized your health through daily health practices that
Right.
reduced your need for that, or prevented the need altogether? And so we kind of take those different, access innovation along with payer innovation and then medical philosophy innovation, smash them together in a delivery model that is very scalable. So it kind of feels like direct primary care, concierge care. Then we layer in this functional medicine approach and we deploy it via those on-site and virtual options. And I think I've created somewhat of an optimized system with the whole idea of how can we use this to change how primary care is delivered across the U.S., not just in a geography
Right.
or around a certain brick and mortar.
This is a very important point, I think, and one of the things that's come up in a lot of the conversations I've had around primary care and to your point, the overworked primary care system that we have in this country. But really, it comes down to care navigation.
Mhm.
It's those,
Yep.
you're diagnosed with something and you're hoping your primary care doc has the bandwidth to be your advocate, your guide, the person, making sure you've got the appointments or at
Mhm.
least talking to the right people.
Yep.
And within certain integrated systems, like out here in California, we have Kaiser Permanente, which, say what you will about it, it is an integrated system. But if you're in the Wild West, which is, the rest of America, um, you don't really have um, quality care navigation. And so am I reading between the lines to understand that what part of what you're doing is that?
Yeah, it's almost, if you look at this from a concept we talk about in financial management, fiduciaries. Like, I'm looking out for your best interest as my client and not my own best interests. And I think if you take that exact same concept and apply it to primary care, where right now I would largely argue primary care providers and hospital-based providers are not fiduciaries of your health. What they're doing is they're providing care, but then they're funneling that care into their own systems and networks, right? And so as
Right,
you get engaged with a health system, you enter that funnel and the mechanisms in place, the business functions in place incentivize certain pathways for that individual that may
right,
not be in your best interest financially or even health wise. And so what we're trying to do is almost become that fiduciary of your health, right? Where we're on your side, we're acting in your best interest.
right.
How do we find alternative networks? So we've curated direct contracting ourselves, and we have preferred networks that we work within. We optimize certain providers within different networks that we're working within with employers. And so how do you really look at the patient's best interest and that business's best interest in funneling that individual to the best and highest quality services at the lowest cost? And I think that's what a true healthcare fiduciary looks like. And so if you take the two industries, compare them against each other, I think that's probably one of the easier ways to look at it.
No, I mean, I think that's brilliant. And I mean, that word fiduciary is one that needs to be more ubiquitous within the world of employee benefits, right? I mean, employers, CEOs, CFOs, VPs of HR, et cetera, they themselves don't understand how to be a fiduciary of their own plans. Okay.
Right.
And that is a problem. And we're starting to see lawsuits and things start to hit. And you've probably seen some of the posts on LinkedIn where people are
Yep.
finding these lawsuits. They're finding that people aren't being responsible for their own employees' money in terms of claim not dollars and cost and all these different things. And I think we're just at the not even the tip of the iceberg. We're the snowflake on top of the tip of the iceberg when it comes to looking
That's,
at what's going to be
yeah.
happening with fiduciary responsibility over the next several years. And I think, you're layering in, and I'm talking mostly financial fiduciary responsibility.
Yeah.
You're layering in another thing called healthcare fiduciary responsibility.
That's correct. Yep, that's exactly right. Not putting it on the provider to just make a decision haphazardly because it's a protocol or an order set or something else, but to weave back in to the clinical interaction what is best for my patient, right? Not what's best for me as a provider or my health system. It's what's best for my patient. And if we start
Right.
changing our thinking in that way, I think clinical practice changes significantly, and I also think system behavior changes significantly.
So your part, describe a little bit more, a couple things, I guess. First thing, describe the
Mhm.
delivery side of what you're doing. Are your deliverers, I mean, are they physicians? Are they nurse practitioners? Are they nurses? Are they all the above?
Yeah, we've tried to find the ideal mix. And if you look at when I started the business, and everybody knows, if you're following healthcare staffing trends, we've talked about a physician shortage for forever, right? It's like
Right.
we're going to
And,
be short
and
this many
burnout.
physicians by 2030. Burnout, all the things, right? And so one of the things that I love about being a nurse is we're the largest workforce in all of US healthcare, right? And we've been talking about this provider shortage for a very long time. And what's happening is you're getting an increase in mid-level providers, right? PAs, nurse practitioners. Now, in some medical settings, having a physician provide the care is warranted, right? Complex medical settings, surgical settings, things that require very intensive medical knowledge and complexity. But when we're talking about primary care, sometimes we overcomplicate it. And the beauty, I think, of what a nurse practitioner is who we use provide, mainly in our model, is that a nurse practitioner can do a large majority of what a physician can do in a primary care setting, but they can do it for half the cost, essentially.
Right.
And so, again, thinking about scalable models in a workforce, nurse practitioners, that is actually increasing significantly to meet the demand of primary care. And so you put those things together and say, we have a cost-effective way of delivering primary care with a workforce that's growing to meet the demand. How do we create an optimized model around this? So
Right.
nurse practitioners and nurses are our main care teams that we deploy for population care. We do have physician oversight for medical practices and clinical pathways and all of that. So we don't want to lose that, but we also want to not use an overly complex, costly system to try to solve healthcare access. And we think this mid-level provider team system can
Yeah.
do that. Yeah. So
Okay.
that's been more of the main reasoning why we've kind of fallen right in the middle of that licensure.
Right. And so your clients are let me ask the question this way. Who are the people you seek to be your clients?
When we're talking with businesses, we're looking at, self-funded employers, 2 to 300 employees and above. You go to those mega employers and they probably had on-site clinics before, right? They're big enough. They've been self-funded for a super long time. And they're like, yeah, having on-site care is definitely makes sense, but they're able to afford it. A segment of the market that this is newer in and hasn't been able to afford it is really in that, 2 or 300 employee life group and above, where maybe it hasn't been cost effective to have an on-site solution.
Yeah.
And sometimes near-site solutions just don't get the right amount of engagement because we've heard employers say, if they're 5 minutes away, they might as well have been 50 minutes away because, you get some people who are just like, I don't care how close it is, I'm not going, right? Unless it's smack dab in front of my face.
Yeah.
And so we've found a way with our model to deploy those clinical teams on site at that manufacturer, at that office, to where that on-site presence can be there, 1, 2, 5 days a week. And so we can fractionalize that clinical resource. The beauty is the consistency of that resource in engaging with that population. And our primary metric of success is engagement. There's a lot of things, as you're aware, in the benefit space from a solution standpoint that it could be the best solution out there in concept.
Right.
But if nobody ever uses it, it's completely worthless, right? And
Yep.
so our metric of success has been engagement. If we're engaging with a population of people, that gives us a front door to be working with them on behaviors and lifestyle changes, health coaching. We're doing system navigation. We're doing primary care, occupational health, all of the above. So, but if I'm not working with that person, I have no opportunity to do that. So for us,
Yeah.
everything starts with engagement and that relationship, and that
Yep.
really centers around being face to face with that person.
Yeah, yeah, no, that's super important. And once you've established a relationship with that patient, you're able to go deeper than probably any normal primary care situation would be, right?
Yeah, exactly right. Yeah, and a lot of people are really put off by the manufacturing model that healthcare has become, where you go into your doctor's office and you wait in a waiting room for 30 minutes, and then you see your provider for 5 minutes, and then you're
Yeah,
discharged and you've been there for 2 hours, and that's all you got.
yeah,
Um, how do you take that and how do you change it over to a patient-friendly model? And
yeah.
so what we've done is, yeah, allow for more time with your provider, easy access. And because we don't bill insurance, we aren't sitting there typing in that computer to generate a billable. We're spending time actually listening and communicating. And if you understand what somebody's needs and goals are, you can really make some good progress.
So your comp model is more of a PEPM for the employer. So if they have 1,000 employees, you're going to charge them something per month per employee to be in the Health Bar universe.
Yep, essentially that, capitated payment where it's a fixed monthly amount. They're buying a clinical resource essentially at
Right.
the end of the day, and saying, hey, we're gonna cap our expense for this resource at this amount, and then our goal, and this is what I say, we have to realign that payer provider relationship where me
Right.
as the provider is not incentivized by doing more to bill more. I'm incentivized to shift as much utilization and claims from higher cost complex situations over to this capitated payment model so I can generate an ROI
Right.
on what we're charging. Yep.
So at some point along the way, I mean, this happens probably every day, there's a patient whereby the work you're doing is now beyond the scope of your ability to serve them, right? They need a specialist, they need something beyond what Health Bar is potentially able to deliver. What does that
Yes.
handoff look like to the network that their employer is contracted with to do the insurance side of that situation?
Yeah, when I first started the business, we wanted to make sure that we positioned ourselves as we're working with local health systems and providers and specialists, not as antagonists and not as, disruptors in that way, but how do we blend into the existing care ecosystem and use it
Right.
appropriately? And so as we're identifying clients with special needs that we need to make a referral to, we'll integrate into, what their tier one network is and what are the higher quality providers in that area, make that referral, make that handoff, and really help that be a seamless event for that individual. And then
Right.
walk alongside of that individual
Right.
along the way. It's not like we disappear after
Right.
we've made that
Well,
specialty
that's the most
referral.
important thing.
We're,
Literally, what you just said there is probably the most important thing that a patient needs to
yeah.
hear is,
Mhm.
we're not leaving you. We're going to be right beside you as you begin to navigate whatever the treatment might be for a chronic illness, a surgery, a cancer, whatever it might be.
Yeah, there's people say like, "Oh, you guys can't treat cancer." Well, of course not. We're primary care, right? That's not our intent. But what is our intent is that as you're going through that cancer treatment, there are a lot of precautions to maintain. And when I was back in the emergency department, how many complications we saw with cancer patients who were neutropenic, who got septic, who had certain complications because of their treatments that what weren't managed well because of bad education, because of, lack of this or that. And so if we can work with these individuals going through complex therapies, recovering from a surgery, preparing for a surgery, or going through something like cancer care, there's so much surrounding those diseases and that treatment that we can provide significant value add through that process. But it's not the flashy work and it's not the sexy work, but it
Well,
makes
no, it's the
such a big
important it's the
difference.
important work, I
Important
mean,
work. Yes.
especially as I think the one of the biggest disconnects in healthcare is the discharge order. So someone is
Mhm.
now leaving the hospital, they've had their surgery, or they spent some time in there for something, and now they're out, and they get scribbled some notes or a PDF or two, and they're sent on their way with, depending on the system that they're coming from, may have limited follow up. So for them to be able to come back into your ecosystem to make sure that discharge is positive, that they're following instructions, that they're doing all the things. I mean, that's got to be that's money right there.
It's huge. Yeah, it's huge. We used to say, and terribly, I hate saying it, but we used to say treat and street, right? It's like, I'm going to treat you, get you out of here, right? Treat you, get you out of here, because a bad turn was more revenue. And so it was
Yeah.
treat and street, right? Get them in, get them out.
Yeah, no, for
Yeah.
sure. So obviously you mentioned self-funded employers. I mean, do you have a sales force going after conversations directly with employers, or are you talking to TPAs or you're talking to brokers? I mean, who are you talking to fill your funnel?
It's a combination of everyone you just mentioned. So we've realized that through this process, health benefits is extremely complicated, and understanding who's providing that advice to employers and how are they crafting those plan designs and what are the networks involved, right? So going direct to employer, there's a whole layer of complexity there that a healthcare provider may not be aware of as they're just providing care. So we quickly started forming relationships with health, benefits agencies, with TPAs, with payers, and said, if we're all working towards making healthcare cheaper and improving access and reducing utilization off of these plans, let's look at implementing a health bar strategy where we're working on a population health level and really significant reducing utilization. This should make everybody happy at the end of the day, right? The insurance
Right.
carriers like, great, less utilization. And benefits agents like, awesome, I have a high performing plan and I look like a genius for bringing health bar in, right?
Right.
Then you have the employer who's saying, my utilization's down and my claims are down. I'm super happy. Then you have their employee who's like, hey, I got better access to healthcare all of a sudden. So there's not many like win-win-win situations, and we really
Yeah.
feel like we potentially created one.
Yeah, I mean, what I love about what you're doing, Nate, is there's so many people throwing tons of technology at healthcare, in many ways, and what you seem to be doing is throwing humanity at healthcare. I mean,
Yeah.
you're really trying to take people on a journey, a health journey, whether to avoid chronic things in the long run, or when they get involved in an acute situation, that you're able to help them manage that journey as well, and I like that. And you and I can have a conversation beyond the scope of this
Mhm.
podcast. If you want some insights, deeper insights into how brokers think, and
Yeah.
stuff like that, I'm more than happy to
Mhm.
if you want to pick my brain about those kind of things. I'm
Yeah.
happy to help dig in with you on
Yeah.
on that, because I mean, different brokers will have different incentives in order to do what they all say they want to do what you're doing,
Right.
but
Yeah.
it ain't so black and white, right? So
No. Yeah.
and there's ways to access data. Anyway, we'll talk another time about that offline. Um,
Yes.
but at the same time, I feel like, what you're doing, how challenging is it to scale this, right? I
Mhm.
mean, there's lots of people that need help in this country, and there's a lot of people, a lot of organizations that can use your solution. And to your point, the mid-market, to me, and that is that
Mhm.
250 to 5,000 size
Mhm.
group, is the perfect. I mean, they're not enterprise level, to your point, so they may not have their own chief medical officer. They may have some third party solutions, but you're coming to the table with a real thing that can help people, save, on their long-term costs. And so, given that the market is there for you,
Mhm.
how do you scale this? You're located in Michigan. I know. I mean, I looked at the map on your
Yep.
website, so you've got, clients looked like in about 20 states ish.
Yeah. 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 If you look at it, we're combining the on-site and virtual as table stakes, right? So you need a virtual element of anything you do nowadays, given the world we live in. Our tip of the spear is our on-site program, on-site, with in 5 states with a variety of employers. We're headquartered in Michigan, and we have a density here that we're continuing to expand. But when I was originally creating the model, I thought that it might become a franchise. Honestly, like, how do we
Mm,
create a package or a system of care that can be replicated anywhere? Healthcare is ubiquitous. Primary care needs are everywhere, right? There's really
yeah,
no corner that this couldn't exist in. The economy of scale with the size employers and the economics of it is really what we're trying to fine tune and tweak. So right now we're going after those, 200 to 5,000 size employers. We've been more opportunistic up to this point. We have a sales team that's out there. We have great benefits agencies and brokers and TPAs, some captives who are starting to leverage our solution. But really, we've grown a lot just now, just over the past, 4.5, 5 years out of word of mouth. Do good
that's
care,
great.
take good
No,
care
that's
of
great.
people, and do that. But we would love, I think as we're building it, we want this system of care to be available to every market, to everybody, using employers as that kind of central access point
Yeah,
to individuals, and we think we can do that. Provider, for us, we find the right provider teams, those clinicians to plug into our system to make it go. But as I said, using that nurse practitioner first model and supported by nursing, we think that we can do that and find a viable workforce in most communities.
Are you finding your local providers that you're working with tend to be, well, if they're nurse practitioners, PAs, nurses and stuff, it's probably a little less complex, because that may be a more flexible ecosystem. But docs these days, I mean, I was actually interviewing last week the gentleman who is the new, well, he started actually, it's called the California Physicians Association, and it's an association which is representing all independent physicians, well, independent physicians in California. And he
Yep.
was talking about the statistics about how now, you're down to about 25% ish of docs being independent. Most have
Yeah.
been they're all getting gobbled up by systems, they're getting gobbled up by private equity, they're getting gobbled up
Hmm.
by insurance companies. So
Yep.
so who are you bringing into the health bar fold?
We have our health bar services proper, which is kind of our care team structure, that pop health side. We're building referral networks around us. So think of your physical therapists, think of your labs and radiology providers, independents. And that's really, I think as we discussed before, a little bit of that conference that we'll be putting on here in April of next year is it's how do we start creating structure and a framework around this independent ecosystem of healthcare delivery. And very much a part of that is direct primary care or independent physician practice as we are continuing to do our work. We're definitely not against having independent practice. It's actually fantastic to have because we understand the limitations of our model is where we're not building a brick and mortar facility to go drive to. We're embedding ourselves into physical infrastructure to enhance healthcare access. But some people prefer to go to a traditional office to receive their medical care. So I think as I look at it, and some people be like, oh, this is a competitor of yours at Health Bar. And I look at it and say, no, these are collaborators in the work
Right,
that we're doing because
right.
we need all of us to be synergizing around these efforts and creating systems that work together.
Yep.
Because yeah, if we look at each other as competition continuously, the health system's just going to be over here laughing at us while we eat each other up.
Yep.
And it's like, no, guys, like let's look at this from a more focused and hope-filled lens of fixing the broader problem and understanding people will access healthcare in very different ways, and we should present them with those options.
No, for sure, for sure. No, I really appreciate, all that vision. And so, we're coming up on a little over half an hour here in our conversation. So where I want to kind of end this is, that question you and I discussed. You're now building out something which is a piece of the overall
Mhm.
healthcare puzzle and the solution, right?
Yep.
You're going after a specific piece of that, and you're actually creating a piece of that. You're bringing a novel idea, which you would think wouldn't be so novel, but it's kind of novel of what you're doing into
Yeah.
the marketplace.
Yep.
But we're also having to live within the confines of the existing, employer benefit program, whether it's a fully insured contract with an insurer or a self-insured contract with stop law, all the mess that is
Yep.
employee benefits and insurance and all the things. Um, but also, the way I look at it is someone who is becoming of an age where I'll be eligible for Medicare in the not too distant future. Where I look
Yep.
at that as an interesting solution out there because wow, what we have in one sense is a solution that exists, but we have all these other solutions that run in parallel or et cetera before you get to that point. Um,
Mhm.
you know, if you knowing what you know, working on the hospital side, knowing payer solutions, knowing all the things you do,
Mhm.
um, here's a white piece of paper, Nate. If you had to redraw what
Mhm.
healthcare looks like in America, what does that look like to you?
Yeah. Oh, like the most complex question to ever be asked. No, it's no, really, I think if I'm starting from the insurance side, how do we fund healthcare, right? We use insurance as a primary payer model. What I think a lot about is why don't we look at health insurance kind of like we do other insurance products, like our car insurance or home insurance? Let's insure against catastrophic and
Right.
larger style events. Let's look at everything else in the healthcare ecosystem as more of this transparent, cash-based. ecosystem where we're creating some level of consumerism around keeping yourself healthy. And that includes preventative care, it includes primary care, acute, some minor acute injury illness care, things that should be consumable and transparent. And then, let's look at, emergency care and above as more of this complex care side of things. And so if I were to, wipe the slate clean to start with a, blank slate, I'd first look at changing that payer model on that side and say, let's ensure for the catastrophic.
Right.
Let's create cash-based ecosystems that are transparent for more of this outpatient consumable and empower our populations to take
Yep.
care of themselves on that end of it.
Yep.
Now I look at care delivery structures and say, okay, how do we almost swing the pendulum back to where it was to make healthcare more localized and more accessible and relationship based? And
Yep.
so I look at really that, that fragmentation of primary care almost out of the traditional health systems to
Right.
take that funnel mechanism away. And so you have independent primary care that's dotted all around, kind of like direct primary care in our model and different things like that are working with the right incentive structure for a population and can provide that care to people. So, change that payer model, change the primary care delivery model, look at our healthcare institutions as complex care. I mean, if I ever get really sick or have to have a surgery, like I want a really good hospital to go to, right? So I don't want that to go away. I just think the incentive models and structures that we have surrounding them need to change. And then I think, I do think that hospital consolidation it has been a very negative thing. It's
Mhm.
created a lot of unfortunate capitalism in healthcare. And so, how do we look at more of this decentralized hospital structures where you have local care embedded within communities that can, have a lot of robustness? So, I think we
Yeah.
solve for these things in a wide variety of ways, with advanced technologies and remote patient monitoring and wearables, innovative care delivery models like Health Bar. You look at, alternative payer systems like we're looking to create that also, do that. And I think we create change in parallel to our existing healthcare system and really force its hand to
Yeah.
change versus trying to reform our current system because I don't think there's enough incentive to do that.
Yeah, and there's just too many forces at work to keep the status quo. But I
Yes.
think we've hit a tipping point in this country, and I saw it coming when,
Mhm.
I look back in my early career in as an insurance broker when a reasonably, or actually a very good health insurance plan in 2003 would cost an employer $150 a month to insure an employee and $400 to insure a family. Okay, we've now
Yes.
basically added a zero, you know,
Mhm. Yes.
and it's gotten to the point where it's unsustainable. So things have to start changing. And unfortunately, I jokingly call the healthcare world that we live in is the blind leading the blind.
Yes.
No one understands. Politicians certainly don't.
Yep.
They're just looking for the next soundbite, and people within even a system or an insurer, they're just sort of hyper focused on the thing they do. And
Yeah.
nobody ever takes the helicopter up to, 50,000 feet or the plane up to 50,000 feet and
Mhm.
tries to see this from a systemic point of view. So I
Yeah.
applaud what you're doing in trying to make a difference in a way that I think, you know, gets people thinking about being better, keeping care local, and most importantly, helping people navigate care. Because if you're helping them navigate care well, the cost will go down because there'll be
Yes.
less waste. There'll be less people going back into the hospital. There'll be people who will avoid even going to the hospital to begin with because they've taken care of themselves, properly even before they get to that point. So,
That's
good on
correct.
you for doing
Mhm.
the work you're doing.
No, yeah, appreciate that. It's, hopefully we hope we can act as a beacon of hope or an example of it's possible, really. I mean, and we're going to continue to do our work in our populations and in our segments. And we hope there are many more that come alongside of us and with us and behind us. And so there's great work being done. We need more of it. I'd love to see more competition in the market and just really this whole idea proliferate and gain more traction. Because I think I think we're onto something. We're making a good change, and I think
Yeah, yeah.
we can do it. Hmm.
Yeah, I mean, just one other question about Health Bar. Did you bootstrap this thing, or did you get funding?
I bootstrapped it. So
Wow,
I'm a clinician, right? So it's a services business. You start doing it. I
good for
started during the
you.
pan yeah, started during the pandemic. So we actually did a lot of pandemic services to start, which was a quick in, and then developed core systems and processes, and got into our next stage of the business. But yeah, no, this is a bootstrap venture. Definitely learned a lot of hard lessons. That's a
Oh,
whole
I
nother
bet. Yeah,
story.
yeah, yeah. Good
Yeah,
for you. Good for
yeah,
you.
yeah.
Well, my last question, which I always ask my guests, I don't know if are you much of a wine drinker?
I do love a good wine. Yes.
So good. So basically, because I actually on the side I have this an Instagram called Vines with Vinny, and I talk about wine and always interested in what people like to drink. So do you have a
Yeah.
favorite grape region? Tell me about your favorite wine.
Yeah, I mean, I really like a good Cabernet. It's always a go-to, but as I've started to appreciate wines a little bit more, I've gotten into more of a Bordeaux wine. And so really like a good Bordeaux or really good Zinfandel
Okay.
is also good options. But reds are preferable. I like drier reds with some complexity to them. I live in here in Michigan, right? And a lot of people don't see Michigan as wine country, but we actually
Yeah.
have some very nice I would say white wines, so Chardonnays or some Pinot Grigios that are grown alongside of our Lake Michigan lakeshore.
Yep.
And so, if you're ever into some really good white wine,
Yeah.
I would say come and try ours here in Michigan. Our red wine sucks, so don't come here for that.
Well, no, that's good to know. I mean, I think there's a lot of
Yeah,
wine regions. I mean, I live an hour from Napa Valley, so I mean, you need a Cabernet. I'm your guy. But when
yeah,
it comes to other wine regions, I know about Michigan, upstate New
mhm,
York, Virginia. I mean, even Texas. I mean, all around the country, they're growing, grapes. And so, I appreciate that you sharing that. Well.
yeah,
Nate, thank you. I mean, this was a great conversation. I appreciate your insights. I appreciate what you're doing for the industry. And thank you for being a guest.
yeah. No, appreciate it. Great conversation. Looking forward to the next.
Okay, sounds good. This podcast reflects the personal views of the host and guests, not their employers or sponsors. See you next time.